Invite the next speaker, Dr. Manish Bansal, on stroke prevention in atrial fibrillation. So, I think the end of the day, the atrial fibrillation is the biggest complication is stroke, and that is big strokes. So we know that the cardioembolic strokes are the biggest stroke. So over to Dr. Manish, how to prevent it.
Yeah, good morning, everyone. First of all, I thank Dr. Gupta for inviting me for this meeting, this presentation. My topic is little different. I'll be focusing on rivaroxaban while talking about stroke prevention in AF. So, as mentioned in previous presentation also and by Dr. Viveka just now, that stroke prevention is one of the most important goals of AF management because stroke is the most devastating complication of AF, and we use CHADS-VASc score most commonly to assess stroke risk in these patients. There are other risk scores also which can be used, but this is the one which is most commonly used. The guidelines recommend that any patient who's got CHADS-VASc score of 2 or more, now CHADS-VA, because this X category has been removed from the score. So 2 or more has class 1 indication for anticoagulation, and if score is 1, then it's class 2A. And whenever we want to use any anticoagulant, then unless the patient has a mechanical valve or has mitral stenosis, rheumatic mitral stenosis of moderate or severe variety, then NOACs are definite first choice over and above vitamin K antagonist. Now, while we are using anticoagulants, we also need to be cognizant of bleeding risk. Again, there are various risk scores that can help us assess the bleeding risk. But even if the bleeding risk is high, it doesn't mean that we are not going to use anticoagulation. Anticoagulation must be used, but at the same time, try to minimize the risk factors that can increase the risk of bleeding, like concomitant antiplatelets, NSAIDs, uncontrolled hypertension, or heavy alcohol use. As we can see here, the data has shown that patients who don't have any of these risk factors, their bleeding risk is just 50% of what would happen if they had one or more of these risk factors. So among NOACs, there are 4 agents available. The fourth one, edoxaban, has also become available in India. Other 3 had been in use for many years. These are the doses mentioned here, standard doses, and then the criteria for using lower doses. Now, as we know, apixaban has been the most commonly used agent in our country. But the data regarding these agents have come from different trials. There is no head-to-head comparison of any of these 2 agents. So whatever we infer are from individual trials. And whenever we look at individual trials, we uh, need to be aware of the differences in the patient population and various trial characteristics before we reach any conclusion. So these trials showed that dabigatran 150 BD was the only agent which reduced the risk of ischemic stroke. Other agents were as good as vitamin K antagonist. Bleeding risk was reduced by apixaban, major bleeding, but intracranial bleeding was reduced by all the 4 agents. So now, as I was saying, that the trials that have shown the benefit of these agents have had significant differences that we need to be aware of. And first and foremost is that in the trial that tested rivaroxaban, the Rocket AF, the mean chat score was significantly higher as compared to the other trials that tested apixaban or dabigatran. As we can see here, it was 3.5 compared to 2.2 or 2.1. So that means that the patient included in Rocket AF trial had 3 times higher risk of stroke or TIS compared to Aristotle trial or Rely trial. Now this is very important because we know that when the stroke risk is very high, then NOACs do not fare as well as uh, vitamin K antagonists, as we have seen in moderate or severe rheumatic MS or patients with prosthetic mitral valve, mechanical valve, or even in Epla syndrome. These are conditions where the stroke risk is very high, thrombotic risk, and NOACs fail to offer the same efficacy as vitamin K antagonists. So, in these patients with such high CHAT score, rivaroxaban was as effective as vitamin K antagonist. It was not inferior to vitamin K antagonist. That is a testament to its efficacy. Now, at the same time, when the stroke risk is high, the bleeding risk is also generally higher. That we can make out from this chart here, which shows that in Rocket AF, 63% patients had Hasbled score 3 or more, whereas only 10% in the dabigatran trial and 23% in the apixaban trial had this high bleeding risk. Therefore, the bleeding events being higher in rivaroxaban trial are not exception. They are because the patients were at higher risk of events. And if we look at the chat score and look at the bleeding risk, they are almost uh, proportional. So in Aristotle, lower chat score, lower bleeding risk. Rocket F, higher chat score, higher bleeding risk. If you look at the other trial with rivaroxaban, this is an observation study. It had CHAD score of 2, same as Aristotle, and the bleeding risk was same. So no difference. Which means that if in Rocket AF we had lower bleeding risk patients, we would have most likely had lower bleeding risk, lower bleeding events in these patients. Now the other important point regarding rivaroxaban and other NOACs is importance of diabetes. So let's take this example. This is a 68-year-old lady, has diabetes, hypertension, dyslipidemia, has been on all the important therapies. Creatinine clearance is normal. She is diagnosed with AF. Which NOAC should we choose? All the three agents are all equal. Let us see. So in the Rocket AF, 40% patients had diabetes. This is the highest proportion of diabetes patients in any of these 4 trials, as we can look at this data here. Now, there was no difference in terms of efficacy between diabetes and non-diabetes patients in all the 4 trials. But bleeding risk in Aristotle trial was significantly higher in diabetes patients as compared to no diabetes. This means that the bleeding protection that apixaban offered was limited only to patients without diabetes. In diabetes patients, it did not offer the bleeding benefit that was there in other patients. And that's why there is FDA label for apixaban that subjects treated with apixaban with diabetes bled more than did subjects without diabetes. Apart from this, in Rocket AF trial, in patients who had diabetes, rivaroxaban also reduced cardiovascular mortality by 20%, a benefit which was not seen with other agents. So here we have Rocket AF data, 20% benefit. Not, this benefit was not seen with other agents. And then more recently, RIVA-DM, which is a prospective observation study, has once again provided more data in support of rivaroxaban in diabetes. So as we can see here, in diabetes patients, there was reduction in stroke risk, reduction in vascular death, reduction in major bleeding and ICH, and reduction in kidney outcomes also. So multiple benefits seen with rivaroxaban. Now moving on to the other important issue is renal dysfunction. So here we have patients, so the same patient, we are following that patient's journey. She developed diabetes, AF, and now 2 years later, she has developed renal dysfunction. Her creatinine has gone up to 2.7, creatinine clearance is now 25. So what should we do? Are all the agents same? So let us look at renal data. Okay. So in Rocket AF trial, there were highest number of patients with significant renal dysfunction between 30 to 50 ml per minute GFR. 1,474 patients, 20% population had this renal dysfunction in which a specific dose of 15 mg OD was used. In case of apixaban trial, Aristotle, only 428 patients had used lower dose, and out of those 428, only 149, so 1.6% of the total population actually had renal dysfunction and was treated with lower dose. So we have very limited data regarding the efficacy of lower dose in renal dysfunction patients with apixaban compared to rivaroxaban. And in Rocket F trial, I'll just take 2 minutes more.
Your question answer session will be out then.
Okay, I'll just finish with this.
Try to sum up.
So, yeah. In Rocket AF, there was no interaction in terms of efficacy regarding renal function. But the fatal bleeding was significantly reduced with rivaroxaban, not published with apixaban so far. And the renal in a very important point, that we often forget is that underdosing is not as benign, because there is evidence to show that when Epic-7 low dose is used, the stroke risk may be increased, and a large observational data has shown that underdosing of Epic-7 is associated with significantly increased risk if the underdosing is inappropriate. So I think I'll end here.
Yeah.
Rivaroxaban, although gives an impression that it is associated with high bleeding risk, but that bleeding risk occurred because of high bleeding risk of the patients who were included in the trial. Rivaroxaban has certain advantages: once daily dosing, efficacy in diabetes patients, efficacy in patients with CKD, and good safety data in elderly patients. Thank you.
Yeah, Dr. Chopra,
Yeah,
please.
Manish, I think it was a brilliant talk. I just two important questions. Number one, you mentioned the mortality benefit is definitely more with the rivaroxaban as compared to apixaban. The only thing is it cardiovascular mortality or it is all-cause mortality? Is there a distinction or there is no distinction?
So, sir, in the data it showed was for diabetes patients. In diabetes patients, there was a reduction in the risk of cardiovascular mortality with rivaroxaban, not with other agents. So it was cardiovascular mortality, not all.
Second important question is not mentioned here, maybe paucity of time. We see rheumatic heart disease with atrial fibrillation. And I think people are recommending now, as per the guidelines, in mild and moderate mitral stenosis with atrial fibrillation. What are your views on this?
So for mild MS, we can use NOAC, but for moderate or severe, the guidelines are still clear that we should be using vitamin K antagonist.
Yeah, so I think up to severe is excluded, but up to moderate also it's been in the guideline now that we can use it. And absolute no for mechanical valves and the LV thrombus, and also they have not been shown to be superior. But I think the stroke prevention wise, rivaroxaban stands tall because it has got a ease of use. So the adverse, the increased rates by missing one dose is much higher of the other agents which are twice a day compared to once a day. So the compliance rate is much better. And of course, smaller dose we have shown to coronary benefit also with this molecule. So probably that will also add to what Dr. Chopra was asking about all-cause mortality and cardiac mortality. Probably that would also contribute to that. And so I think everybody will agree that NOACs has really changed the scenario, how we treat AF and prevention of stroke. So on that note, we'll give a big hand to all the speakers and for giving wonderful job, and over to Dr. Hansa for
Yeah.
the next session.
Thank you all the panelists and the moderators. I'll request you all to please gather here for the felicitation. And in the meantime, I'll thank you, Dr. Manish. Yeah, here. Dr. Rakesh Gupta is going to honor them.